evening.
Good evening.
Hello, ma'am. Hi, Nilima.
Hello, madam. She told me there was something not allowing meeting to start. So give me 2 minutes. That's what Shweta told.
Good evening.
How are you, Subbu? Rested?
Yes, ma'am. All fine.
Did you sleep for 48 hours?
I slept for 24 hours.
48 hours. Wow, that's a luxury.
Slept for 24 hours, yes. That itself was a luxury.
Hello, Dr. Nilima, Dr. Upendra joined?
नहीं उपेंद्र सरांना कॉल करू का?
Actually, he had joined, but there's some technical problem, so he could not enter. Yeah, he's there, but he's waiting in the things.
Room?
Yeah.
Okay, last Shweta.
Shweta, please take Dr. Upendra in the panelist list. Shweta, you're there? DIP?
Yes, she's there.
Yes, doctor, there was no internet at my home and it's
Okay, Dr. Upendra is there. We'll discuss that later. We'll discuss that later. Just take Dr. Upendra.
And even Rajendra Vaidya sir is waiting in the waiting room.
Dr. Monica also, she had sent a message that she was waiting. I can't see her.
I'm not seeing Dr. Monica. I'm seeing Dr. Upendra is already there. Dr. Rajendra Vaidya joined.
नहीं दिसत है.
Okay, all the panelists are there.
Dr. Monica, and I'm not sure about Dr. Samir either.
Dr. Samir is there. Dr. Samir is there. Dr. Samira joined as a panelist. Dr. Monica, I'm not seeing in the waiting also.
I'll give her a call. Is that okay?
Yeah, please.
Yeah, you
please
can,
call her.
please.
Monica is here. Ma'am has named herself as Nilima. Ma'am is
She
here.
was here
Dr.
by
Monica,
the group.
Because that
Ma'am is
was
very
my
much here.
link, I think.
Oh, Dr. Monica, can you please change your name? Rename it. Yeah.
There are two Monicas.
Oh, is it?
So, why is my name appearing as Nilima Bhandarkar? That's because it was my link. No? Oh yes. Okay, I'll change it. Reason,
Dr. Monica
I also
Juneja.
don't have a name.
Anamika.
Just click on those 3 dots at the top of your picture, and then you can change the name.
Samir, you are there. Dr. Samir Dalwai, you are there.
His name is seen over there.
Yeah, I'm seeing. I think Dr. Upendra, it's almost 4:10. First time we got delayed. You can start and they can continue with the.
Let Samir, just Samir.
Oh, he's
switch on
logged
your
in.
camera.
He's there.
And
Where is
Dr.
mute?
Monica Juneja.
I'm just calling her, sir.
Yeah, it's okay. Yeah, she's there. She's there.
And even Vaidya sir has joined.
Hello, good evening.
Hi, good evening.
Good evening, sir. Good evening.
I think Dr. Upendra, please start.
Yeah. A very good evening, friends. This is Dr. Upendra Kinzavadekar, along with my colleagues, Dr. Mahesh Moite, Dr. Rajendra Vaidya, Dr. Nilima Bhandarkar, Dr. Kiran Vaswani. We all welcome you to this yet another fascinating episode of Diamond Jubilee Academic Pearls, being aired on every Tuesday sharp at 4 p.m. right from 1st January. This month, week after week, we have had fascinating sessions starting with Dr. M.K. Sinayar, and then last week, Dr. Sharmila Mukherjee. We have had great sessions on many nuances of developmental pediatrics. And today, I think a child coming with behavioral disorders, a child who is hyperactive, early recognition, and then picking them up in time, early workup, counseling the parents, how to go about it. It's a big question mark in front of a pediatrician who is busy nowadays. And I think post-COVID, all these patients have definitely, all of us have witnessed across the country that they have increased in number, and we should have some approach, some basic foundation which should be ready, which should help as a basic clinician to help these parents. So I'm sure this panel discussion which is going to unfold will have all these things, facets would be clear to us. And who have better than Dr. Sharmila Mukherjee, Dr. Monica Sharma, who are going to moderate this session. And truly, we have a galaxy of speakers across the country, starting from West, North, East, South, Central, from every place. I'm very happy. I welcome each one of you. I won't take all your names because you would be introduced in detail. So thank you so much. And all my colleagues, keep joining on every Tuesday at 4 p.m. for these great episodes. Thank you so much. And let's have great discussion ahead. Thank you.
Thank you, Dr. Upendra, for that, as usual, wonderful preambles. I think today's topic is something which a general pediatrician is supposed to at least recognize those problems, the behavioral issues. Generally, the pediatricians in their office practice in the periphery sees anywhere from sometimes even 50 to 100 patients. And there to recognize this are kind of a seemingly subtle problem, but actually a peak of the iceberg, because we may be picking up hardly few percent and many of them go unnoticed to really get onto really bigger problems in future. And this topic is going to be really very dear to most of the pediatricians. I'm sure I do expect a lot of attendance for the today's program, as well as the revisits for the recorded ones. Without wasting much time, I request Dr. Nilima Bhandarkar to introduce the faculty and then over to the faculty.
I welcome all the panelists and the moderators who are legendary speakers and experts in their field. First moderator is Dr. Sharmila Mukherjee. She is director and professor at Lady Hardinge Medical College and Kalavati Saran Children's Hospital, New Delhi. She is expert in the field of ECD and developmental pediatrics. The second moderator is Dr. Monica Sharma. She has done her MD Pediatrics and plus she is MSc Pediatric Neurodisability. She is professor of and head in charge of Child Developmental Center, Christian Medical College, Ludhiana. She is editor-in-chief of CRISMED Journal of Health and Research. Then we have panelist Dr. Monica Juneja. She is director and professor, head of pediatrics, in charge of Child Developmental Center at Maulana Azad Medical College and Lok Nayak Hospital, New Delhi. And Madam has developed INDT ASD tool for children with ASD. Then another panelist is Dr. Nandita Chatterjee. She is professor and head of pediatrics at MGM Medical College, Kolkata. She is in charge of Unmesh Child Development Center, editor-in-chief of Indian Journal of Growth Development and Behavioral Pediatrics, working with developmentally challenged children for last 16 years. And the last panelist is Dr. Samir Delvai. He is developmental and behavioral pediatrician, founder, director, and consultant at New Horizons Child Developmental Center at Mumbai. It has 5 branches plus online services. He and his team propose social interaction theory of autism and the social, behavioral, and communication sequence of development. He tries to create innovative interventions to children with special needs, and he is the recipient of Rajiv Gandhi Manav Seva Award. So
we have Dr. Subramanian also. Dr. Subramanian.
Yeah.
I will introduce myself. I am Dr. Subramanian. I am a pediatrician and developmental pediatrician from Chennai. We can go ahead with the program. Don't worry, it doesn't matter.
Thank you, sir. Thank you.
It's over to the moderator to take the program further.
Okay, so I'll just share the screen and Dr. Monica and I will be doing the moderation.
Dr. Monica is joined. Dr. Monica.
Dr. Monica Sharma.
Sharma and you are the. So the panelist is not joined yet. Dr. Juneja is not joined yet.
Dr. Juneja had joined.
Can you see her?
Yeah,
okay, fine. Oh,
yeah, she's there.
Can you please rename? Dr. Juneja, can you please rename there?
Okay. Is it in slideshow? Yeah.
Yeah.
Is this apparent?
Yes, yes.
So I will be operating the slides and Dr. Monica K, Monica with a K, will be. So, Dr. Monica, I just request you that when you are doing your part, just keep on saying next, please, so I can operate accordingly. Okay.
Yeah. Works.
So, Dr. Monica, please proceed.
Okay, so we'll start with today's session, and it's a very important session about very common, relatively very common behavioral problem that most of the general pediatricians would be seeing in their office practice. Let's go to the next slide. So just briefly to introduce why we are sitting together here and discussing this topic is that hyperactivity, I'm not saying ADHD, I'm saying hyperactivity is one of the most common observable symptoms. And it's not common because of the incidents only, it's also very common because it is one of the very outwardly disruptive behaviors which comes in the pediatrician's eye very easily. And that is also probably one of the reasons why it often gets mislabeled, and it is one of the commonly mislabeled conditions, or rather the behavioral condition of a child. We need to understand that there could be multiple reasons, multiple presentations, depending upon the age, the time of presentation with this condition. Therefore, it's necessary that a general pediatrician understands that what they are looking at may or may not be what they think it is. And we hope that today, through the various snippets and the cases that we are going to present, most of the people who are attending today's session will be reminded of one or the other child that they have seen in their OPD. And they may have thought, is this hyperactivity? Is this a behavioral disorder? Shall I refer this patient? And let's see if we can answer some of your questions. So with that, let's move on to the first snippet. And the first question and the case scenario that I'm presenting is for Dr. Monica Janeja. And this is a very typical scenario that we see in our OPDs. A single working mother, she brings her 2-year-old daughter with concern about excessive running around, demonstrating temper tantrums when she comes home from work, and she finds it difficult to cope up with this girl and handle her. So would you consider this to be a normal behavior, or when will you consider this to be not normal, ma'am?
Yeah, thank you, Dr. Monica and Dr. Sharmila, for bringing up this very interesting case scenario and very common one. We all know that toddlers are very active in the very active stage of their life. So that is why it is known as terrible toddlers. So when they are learning to walk around or run, so it's a newly gained skill. So they try to practice it a lot, and they are very highly active at this stage. So whenever somebody comes with the concern that my child is hyperactive at this stage, we have to be very careful before labeling this as a disorder. So hyperactivity as a developmental disorder would obviously be manifesting at multiple situations and multiple scenarios. So if this is a working mother, and when she comes home tired and there are other issues which and she may not have so much time or patience to handle the child's activity level and other demands for interaction, then she may get frustrated and might be too much for her rather than a problem in the child. So when we look at these children, we must ensure that the symptoms are, or the hyperactivity is abnormal. And for that, we have to see whether it is manifesting at multiple levels and whether it is so much that everybody around who is taking care of the child gets exhausted by the activity level. Commonly, these children who have ADHD or other reasons for hyperactivity would also have some other problems, like their sleep would not be normal, their sleep would be less, they will have difficulty getting to sleep, they would have too much of tantrums or aggression, and it is not easy to make them sit for even very interesting activities, like if you're telling them a story or if you're singing a rhyme with them. So the child is generally very fidgety and not able to sit around even momentarily. So if all these things are there, then obviously you cannot ignore it. And then it becomes atypical. I hope I've answered the question. If there is anything else, the other panelists can add to it. Thank you.
Thank you, ma'am. We'll move to the next snippet. This is for Dr. Samir. A mother reports that her 10-year-old son always appears hyperactive and loud for some time when he returns home from football practice. Dr. Samir, is this normal? In which other circumstances would you consider hyperactivity of this sort to be situational? And what additional history does a pediatrician need to probe in these kind of cases?
Yeah, so good afternoon, everybody, and thanks to Dr. the President, sir, as well as everybody else here for enabling this wonderful discussion today. So thank you very much. Coming to the question, Dr. Sharmila, I think again, that's a very important discussion that you put up here. And what I'd like to say, of course, the answer is yes, this is normal. And the point again, which was very well made by Dr. Monica, is that hyperactivity is a symptom. Don't label it as a diagnosis until you analyze the symptom in detail and you look at some other co-symptoms. I mean, after all, if you have fever, you don't just say malaria, you look at other signs and symptoms and then come to a diagnosis. And she has very well answered how you look for the other signs. And this child, this boy comes home from football, he's been very excited, he's been very interested in what was happening, a very passionate interest in the sport. He comes back, he's going to be very hyperactive and loud. He's probably telling the mother how the game went, how he had a competition with his the opposite team and things like that. So that's completely normal. Now, when you ask in which circumstances would you consider hyperactivity to be situational, please understand even in football, it's very interesting. It's not the child who's ever responsible, but it's not even the behavior. The real problem is when you know when to do that behavior and when not to do the behavior. So if we are talking about running around on the football field, obviously it's normal because in football he's supposed to do that. But he's running around in the classroom, then that hyperactive behavior becomes abnormal in the classroom, which was normal on the football field. So it is not the hyperactivity or otherwise which is the problem. It is not knowing where to do it and not to do it that is a problem. Even if you look at football, a forward and a midfielder are supposed to be very, very hyperactive. But a defender cannot be so hyperactive running up and down all the time. Otherwise, he'll let goals go in. And the goalie is supposed to be stationary, standing in that 10 feet circle himself. He can't run up and down. So even in a game of football, you have different footballers who have to be differently hyperactive. And this each person has to understand. And that's my answer to that question. As long as the child understands where not to be hyperactive, I think it's normal. And you don't need to look at an ADHD. Because ADHD or other things are where typically the child depicts hyperactivity in multiple situations, in multiple settings, at home also, in the classroom also, in the neighbor's house also, without knowing that he should calm down there. And this causes some loss or problem either and to the child or to the others. So the additional history that a pediatrician needs to probe into is, does he also have this everywhere? Is it provoked? Does he get hyperactive when provoked by somebody? Is he able to calm down and soothe himself soon enough? Or he gets super provoked from the hyperactivity, goes on to aggression and violence. And when calmed down, how soon does he calm down and how soon does he get back to normal life? As long as these things are seen, I don't think you need to worry. The only other history that you need to look into is how is this child's communication and cognition. If his child's cognitive ability is age appropriate, understanding how things work around is fine, as well as his verbal as well as non-verbal communication is fine, then I don't think we need to worry. Thanks.
Thank you. Thank you.
Okay. I think that was a very interesting and memorable simile. I would say that people would be able to understand how to understand the child's behavior. I think two things which have come so far is, one is consider the age and context and the situation. With that, I'll go to the third scenario for Dr. Nandita. Here is a mother of an 8-year-old boy who has epilepsy, and she reports that her son has become fidgety and is unable to sit still after being started on phenytoin. And she's very sure that the symptoms were not there before. So, Dr. Nandita, what do you think the pediatrician should think of? What are the additional points to be asked?
Good afternoon, everybody. Coming to the additional history, yes, parents often do allure various symptoms to a medication. So, though it is possible to have hyperactivity as a result of these medications, there are a couple of things I would like to ask. That is the chronology of events. When has the seizure started? When was the medication started? When was the hyperactivity noted? And how are they related? Because we all know that childhood epilepsy itself may be associated with behavioral issues, which includes hyperactivity. Now, once I'm sure about that, then we will try to understand whether it is really due to phenytoin. One easier way of doing that is to look into the other side effects that phenytoin may cause. So I would definitely like to know about any nausea, difficulty in eating and all, any blurring of vision, poor coordination in the sense the child has difficulty in balancing, writing, and feeding himself, things like that. If these are present, then maybe phenytoin, it's maybe causing the hyperactivity per se. And coming to the cause of other drugs, actually even more than phenytoin, we know phenobarbital does lead to hyperactivity. Apart from that, along with phenytoin in the same line, we should keep in mind about carbamazepine, valproate, and topiramate. So all these medications have this possibility of causing hyperactivity. Thank you.
Thank you, Dr. Nandita. In fact, actually, this case was framed on a patient who has been coming to our epilepsy clinic. And what we did discover was that it was drug related. And that is why I brought in the story, because I was pretty sure that this child had ADHD before and the mother had missed it. But then when we did the probing, it came out to be totally drug induced. So moving on to the next snippet, which is addressed to Dr. Subramaniam. Which medical causes of hyperactivity would you like to exclude in a child before considering a neurodevelopmental or psychiatric cause? And what about in an adolescent?
Good afternoon, everybody. Thanks for this opportunity. As a pediatrician, it's always important for us to consider other medical causes before we are looking at neuropsychiatric or neurodevelopmental issues. So one of the commonest cause of hyperactivity is anemia, iron deficiency anemia. These children iron deficiency anemia can lead to fatigueness, or it can also lead to restlessness. So I think for every child whom we are suspecting hyperactivity, we should look at anemia, see if rule out iron deficiency anemia. There are other thyroid disorders that can cause hyperactivity. Sleep disorders of sleep, where a child has got sleep apnea, a child can present with hyperactivity in the daytime. Lead poisoning, chronic lead poisoning can cause features of hyperactivity. Medications like, ma'am had told about anticonvulsant medications like phenytoin, phenobarbital, and other medications. But then there are other common medicines like decongestants that we use in as part of cough syrups, antihistamines, corticosteroids, bronchodilators. These are very commonly used medicines that can present and manifest, make the child manifest with behavior suggestive of hyperactivity. Giving caffeine containing beverages is not uncommon, especially in my part of the world. Coffee is not a very uncommon beverage that a child takes, and when introduced early, that can also cause features of hyperactivity. And underlying epilepsy can itself manifest with hyperactivity. Metabolic disorders like phenylketonuria can have behavioral issues. Children, when they have ear infections, can manifest with features of hyperactivity. Some children with fever, they manifest features of hyperactivity. So there are a lot of other causes of hyperactivity. A thorough clinical examination, along with a good clinical history, is very important even before we make consider a diagnosis of neurodevelopmental or psychiatric causes of hyperactivity.
So the causes of hyperactivity that you just enumerated, Dr. Subramaniam, would there be any additional causes in an adolescent?
Ma'am, to my knowledge, they're all very similar when you're looking at medical causes. I would definitely invite other panelists to add if there are any that I missed out.
Maybe like
Dr. Samir wants to say, yes.
Dr. Samir wants to say something.
Yeah, I think everybody has covered the points very well, but overall, for everybody, one point to remember is 2-3 things have to be kept in mind by the pediatricians. One is basically child with allergies can also be exhibiting signs of inattention, hyperactivity, impulsivity. The second is sleep problems. Now these sleep problems are all situational. Kids come home late. After that, the parents come home after the job. Then they cook food and then they have dinner. And after that, there is homework. Then there is a fight over homework. Then there is a pacifying of the fight. Then there is Netflix to be watched. So by the time the child goes to sleep, it is in Bombay very common 1:30, 2 a.m. And after that, in the morning, the school bus comes 1 hour before the school starts. So the child is half asleep and wakes up and goes. So all these things are adding on. And of course, as Dr. Subramaniam said, adenoids and all these problems are very common. But in addition to all this, the house atmosphere is very common. We have a lot of children whose parents come to the clinic here saying my child is hyperactive. You ask them their schedule. The child leaves home at 6:30, comes home, goes directly from the school to some daycare. From the daycare, goes to tuitions. From tuitions, goes to classes. Mother picks up the child at 7 p.m. Then they come home and then the evening routine follows. And then if there's a complaint that on Saturday, I asked them, where were you there to see the child is hyperactive? Said, no, on a holiday when we had gone, we saw he was very hyperactive on a Sunday. Said, that's the only time he probably sees you. So all the family structure and how hyperactive or how badly the child is being treated at home is very important. And finally, never forget to rule out child physical abuse or sexual abuse. Thank you.
Right. Thank you so much. I think we've covered all the points. What I wanted from the adolescent was basically because this is something that we usually don't probe into, but substance abuse and withdrawal from drugs is also another common, one of the common manifestations of that is also hyperactivity. So that also needs to be added to the entire panorama of additional questions. So that was a great discussion in the first section, and all the panelists have come to us. I mean, it's very, very, very obvious that a detailed history examination observation is required. So now we will move to the first case in depth, which is a 5-year-old boy. And the child has been brought by his parents because they have noticed certain behavioral issues since around 2 years, when he was around 3 years, since 2 years duration. And he was around 3 years old. He is currently in upper KG from school, and the parents are receiving complaints from the school teachers. Apparently, he can't sit still. He keeps on getting up in the middle of the class. He's very talkative. He interrupts the teacher, has decreased attention. And because of that, there's a lot of disturbance in the class. In addition, he's also having poor school performance compared to his peers. The parents, on probing, say that the child does understand instructions at home, but there are issues in his finishing his work. He forgets to do certain activities of daily living, like brushing his teeth, unless he's reminded repetitively. He doesn't have problems in learning skills, but he keeps on forgetting. He likes to have rough and tumble play with his brother, and doesn't really enjoy quiet time activities like coloring or building blocks, etc. He does like TV, but even during his favorite program, he keeps on getting up. There's no significant past history. The child is a second issue of a non-consanguineous union. He has a 10-year-old healthy brother who does not have similar complaints. The child was born in a hospital. It was a normal vaginal delivery. The APGAR score was normal. Though he was low birth weight, he was discharged within 24 hours of birth. According to the mother, what she can remember, there's no delay in any acquisition of the milestones across all domains. She does say that the child has temper tantrums on occasion, and that's usually when he doesn't get his way and when he has to wait for his turn. He says no a lot. He argues and will usually not listen the first time he's told to do something. It's only when the mother becomes firm or the father has to threaten him that he hears and listens to his parents. In school, the social interaction with his peers is usually good, but he often has fights. But on the whole, he enjoys the school. So the examination is normal in terms of the vitals as well as the anthropometry. There are no adenoid facies, dysmorphism, or neurocutaneous markers. Essentially, the systemic examination is also normal. The developmental assessment and the neurological examination is within normal limits. So the first question is addressed to Dr. Monica Juneja. What will be the next step in evaluation, and what differentials will you consider?
So, Dr. Sharmila, we have already heard in the first session that hyperactivity is not the, ADHD is not the only etiology for hyperactivity. So if a child has been brought with the symptomatology, I would also first like to see how's the child's sleep like.
Okay, so ma'am, you asked me the question.
We have some information about the child's sleep, his screen.
Okay. Ma'am, so yes, for the sleep, the answer to that is that the child, it's difficult for the child to go to sleep, but once he does fall asleep, the sleep is uninterrupted. It's a little difficult for him to wake up in the morning, but there is no daytime sleepiness.
Okay, so so sleep seems generally fine for this child, except the somewhat delayed onset at the beginning. What about his screen time?
His screen time, according to what the parents have reported, is that he sees around an hour and a half per day, maybe a little more, 2 hours, 2.5 on Sundays. And he keeps on getting up during the programs.
Okay. The other issue that we need to probe is the family environment. So how's the family scenario? What is the parenting like? How much do the parents give time to the child, and the quality of time and the boundary setting? So can you tell me something about that as well?
Sure. The child belongs to a joint family, and he gets along pretty well with his cousins and his chachi, mami, masi. And the child's parents are both working. They come back home by around 6:30. The child comes back from school by around 2. After that, his needs and all are looked after by the other women in the family and his uncles as well. And after they come back from work, the parents are spending a lot of time. And on probing, their parenting practices also seem to be pretty good. And the interpersonal relationships between the mother and father and with the siblings and cousins on superficial probing seem to be pretty okay.
Okay, so even though Dr. Sharmila, you are telling me all these things very smoothly, I can understand and appreciate how much time it would have taken you to get all these details from the family. So apart from this, what about the social interaction of this child? How is he with his peers?
Okay, so the social interaction of this child is okay. He, as I said, he does get along well with his friends, but they do have squabbles when he wants to get his turn first. But otherwise, the eye contact and social interaction with both peers as well as older kids, his younger cousins and his uncle, aunts, and people outside the family as well as in the school are okay. There are no complaints regarding that.
Okay, so superficially, I think social interaction also seems to be fine. And why are we concerned about it is because autism is a very important cause for hyperactivity or ADHD-like symptoms, and it is a common misdiagnosis in these children. So we have also commonly seen that if you ask the parents, how is a peer interaction, they might say that everything is hunky-dory, but when you go into the depth of it, you may find out some issues about the actual peer interaction. So I hope a detailed evaluation of peer interaction has been done. And based on that only, we are saying that the peer interaction is good.
Absolutely, ma'am.
Peer interaction and other things.
Can I just add over here? What we did was that we asked the parents to make small clips of videos of the child playing with his cousins, playing at school in his school environment, and across settings, all the videos of the social interaction, which were filmed while the child was not aware of it, seemed absolutely age appropriate.
Great. So you have taken care of that. So apart from this, so once you've taken all this history, we have also should rule out other medical causes, which we have already discussed. So before we go into investigation, what observations you would like to tell us that, okay, there is nothing abnormal apart from hyperactivity or inattention in this child?
Okay, so when he was in the clinic, the child's eye contact was good with his parents, with us, with the other people, with the other kids who were there in the clinic. And we saw that we heard his speech. His speech was fluent, and he also used gestures and he understood gestures. And although he kept on getting up and he kept on asking his parents, ki ghar jana hai, kab jayenge? But on the whole, the interaction was fine. We gave him a couple of toys. He played with each toy, his favorite toys. Incidentally, his father had told us that he liked cars. So he played with cars, but he kept on picking up one car. Then after some time, he left it. There was a toolbox. He played with that, but his attention was not sustained.
Okay. Wow. So that is a pretty elaborate evaluation that you have done. So I'm also especially impressed by your assessment of play, because play is one part which we commonly forget. And it's a window to child's thought process, the intelligence, the speech, and the other functioning. So thanks for highlighting the play observations in this case scenario. So apart from this, the other thing that I would like to know before we go ahead is, what about the child's vision and hearing?
Yes.
And Yeah. So please.
Although the parents, when we probe them on history, the parents did not come up with any apparent visual or hearing impairment or difficulties, but still we did get a formal assessment, because sometimes these can go undetected even by parents, and the hearing assessment was normal and the visual acuity was also normal.
Great. I think apart from all this, we should rule out the physical abuse or history of sexual abuse, depression, and other causes which can manifest like this. If it was a recent onset hyperactivity, then neurodegenerative disorders are also other things which we should look for, in epilepsy. So all that. So what investigations as a neurodevelopmental pediatrician you would like to do in this child? I'm sorry, it is going the other way around.
I was a little stumped over there. I said, "Ye ho kya raha hai?" Ma'am, can we go back to the reversal of roles? Now that you have all the history, the information, the observation, and we've ruled out sensory impairment, on the clinical profile, what clinical and behavioral profile, what differentials will you consider?
Okay, so we know this child is hyperactive, and this child has inattention, and this manifesting as a poor school performance. So apart from ADHD, which is a very obvious diagnosis in this child, because both the domains are affected, the activity level and the attention level, and it is also impacting the activities of daily living of this child, especially the academics and his interaction with other people. So ADHD is a very important diagnosis in this child. But we should also remember, so all the criteria of the ADHD are being fulfilled in this child. If we go by DSM-5, so there would be more, and we have to look at how many symptoms are there. So age of onset is obviously less than 12 years. There would be, if you look at each symptom wise, there would be more than six or more symptoms which would be manifesting in this child. And it is manifesting in more than 2 or more settings. So it is overall fulfilling the criteria for ADHD. But apart from ADHD, whenever there is poor school performance, we must look at the specific learning disability as a cause for ADHD, like symptoms, because they are very commonly comorbid conditions. And we have to be very careful about assessing one as well as the other, because it is difficult to say whether egg came first or the hen. So both go hand in hand, and we must rule out that, or evaluate for that, not rule out, because they are very commonly comorbid. Then attention level and activity level are also affected by the intelligence level or cognition. So proper or formal IQ assessment would also be required in this child. Then we have already discussed autism spectrum disorder as a cause for the hyperactivity and impulsivity or inattention symptomatology. So these are the other things which I would like to definitely look into before I make a sole diagnosis of ADHD in this child. So anything else you want me to elaborate on? Because I think the time is...
No, I think that's wonderful. Thank you so much, ma'am. So we're assuming where we have made a final diagnosis after everything that the child has ADHD. So Dr. Nandita, as a general pediatrician, what will you tell the parents of this child with ADHD before you refer him to a developmental pediatrician?
Okay, in this particular case, as a general pediatrician, when I'm first seeing the child, if I have been taking a history and following up the history the way you have wonderfully presented it, and if I can analyze it as Dr. Monica has done, looking at which of the features are pointing towards impulsivity, which of them are pointing towards inattentiveness, on one hand, suggesting ADHD, on the other hand, the sociable nature of the child, the interactive nature of the child, sort of clearing out that maybe it is not a child with autism. So I do now have an impression that possibly, most likely, I'm dealing with a child with ADHD. Keeping this in mind, as a general pediatrician, I don't have the diagnosis.
Ma'am, can I interrupt you for a moment?
Yes.
I'm so sorry. I just got a brainwave right now. The way Dr. Monica and I did that role play. Can you do a role play? And I'm really sorry. I mean, I hate to put you on the spot. But suppose can you just counsel me, considering me to be the mother of this child, so that I land up in either Dr. Dalvai's clinic or Dr. Monica's clinic or Dr. Monica J's clinic or Dr. Monica Sharma's clinic. So you have to convince me, because इसको तो बताया गया है कि इसका बाप भी ऐसा ही था, तो so what if this child has this problem?
So this child is having certain problems, as we've just mentioned. There is definitely evidence of inattentiveness, impulsivity. As a result, not being able to do well in school. There are complaints coming in. So as a parent, the parent will be feeling, yes, there is some problem. I will not give a definite diagnosis, but what I can tell the parent is your child does have a problem. So as a mother, I would like to explain what the situation is. That do not, first of all, do not think that your child is doing it on purpose. It's a misbehavior that the child is doing it on purpose. Do not reprimand the child.
So, madam, आप ये कह रहे हैं that you're saying that ये शरारती नहीं है?
No, there is a problem in your child.
He's not doing it on purpose. He's not naughty.
No, he has certain issues which we need to look into, and there are ways in which you can handle your child so that the problem may be controlled to some extent. So if you understand that your child is having a problem which you can help him out of, then it will be easier for you to interact. You will come closer to your child, try to understand what he is doing, why he is doing it.
But then if I take him to the developmental pediatrician, then what will I tell the school people? They will say that they will chuck him out of school. How can I do that?
Before we go into all that, of course, your child will need a definite diagnosis. And for that, we will be sending your child to a developmental pediatrician, because the child definitely needs a proper evaluation, proper diagnosis, and proper management in terms of behavioral management, therapy, and maybe medication. But it is not only what the therapist or the doctor, specialist doctor would do, it is also what you will do with your child that's going to make a lot of difference. So you must maintain a proper routine in school from morning till night. It should be a structured and predictable routine. These children tend to act out more if it is not in a structured platform. The calm should be maintained. And also,
can I interrupt you here?
Yes.
I am still not convinced about taking him to the developmental pediatrician right now. So how can you give me one clinching argument that will send me there and not send me roaming around all over the place, the way parents of children with ADHD do?
Well, what I would say here is, apart from the parental care that we would be advising on, you need a definite diagnosis. I'm telling you that your child has a problem. Are you convinced? No, because I couldn't really tell you exactly where the problem is. But it is the developmental pediatrician who will do that final assessment, give you the diagnosis. And if you know your child has typhoid fever, you're going to treat the child. You're not going to say, why are you telling me you're sick? Just like that, if your child has ADHD, you will go on to managing the child.
Wonderful, wonderful, wonderful. So that is the magic of the situation. You have to explain it at the level of the parent's understanding. You have to, and only then will the parent go to the developmental pediatrician, because they have all these multiple issues, taboos, etc., etc. And that example that you gave was fabulous. Ki bukhar ki dawai se nahi chalega. You have to address the root of the cause of the fever. Wonderful. So moving on to Dr. Subramaniam, can you briefly outline the modalities of management for a child with ADHD?
Thank you, ma'am. The modalities of management are mainly with respect to behavioral interventions and medical interventions. Behavioral interventions are both for parents, where parental training like parent-child interaction therapy, PCIT, is being recommended in various places, and behavioral therapy for the child itself at an younger age. And medical management includes stimulants and non-stimulants. Stimulant drugs are drugs with like methylphenidate or amphetamine based drugs, and non-stimulants are used as second line, like your atomoxetine are some of the drugs that are used. And over and above these medical management, behavioral therapy is definitely is going to be of a lot of good use. And education interventions, like if the child has got an associated learning issues, specific learning disability, remedial education will help the child a lot. And like what Madam had told, whether it's the chicken or the egg business, we address both the chicken and the egg, and we have to address both educational issues and also the behavioral issues simultaneously. We'll be able to do that. We also need to work with the school to work for classroom accommodations, like giving preferential seating for the child, then giving excess time for the child to finish the assessments, assignments and tests, and try and give an arrangement where there is reduced distractions. Try and give lot of visual indication prompts for the child stuck in various places to ensure that the child does not forget to do his usual activity. And these children often have, as they go towards adolescence, have other psychiatric and psychological and behavioral issues, and they would need a lot of counseling. And once they come of the age where they can reflect on themselves, their actions, and they are able to make those corrections, CBT, cognitive behavioral therapy, also would help. Support groups are very useful both for parents and children of these children. Exercise and is very important, and a lot of children with good amount of physical activity do calm down a lot more. So I would definitely recommend exercise, especially before going to school in the morning. And a structured routine will help these children go a long way in organizing their life, and their ability to be independent definitely blooms up once we are able to give them more a structured routine. These are some of the things that I would follow quickly.
Wonderful. You've covered everything holistically, from the pharmacological to the non-pharmacological to the educational to the scholastic to the examination benefits, and to strategies to dissipate the extra energy. I think everything has been covered. So we'll move on to the last question to Dr. Dalwai. I think we'll use the same mode that I used with Dr. Nandita, so that I am not accused of being partial to her or impartial to her. Like, suppose as now, what would you like the general pediatrician to do? Like, suppose I'm the general pediatrician and you're the developmental pediatrician. What would you like me to do to ensure that the family of this child complies with the management plan that you have beautifully designed for the child's needs and his family?
Yeah, so actually I'm going to differ a little bit here. I don't think that this child needs any reference at all. And I'm going to tell the development pediatrician that the first thing you need to believe, this is entirely your case and you need to handle it. Because at 5 years, I don't know what great scholastic loss we are talking about. No doubt the parents and the school may tell you, because today at 5-year-old, you are expected to know Shakespeare. But I don't think I agree with that if the school tells them that your child is a school failure. So I would tell the mother, I would tell the pediatrician to tell the mother, tell her that this is something that can be handled by the general pediatrician and by the family. And the way of doing it is to understand that if you look at the child's, the whole issue is to ask what is happening in the child's life. I would tell the general pediatrician to ask that. And already outnumbered so many conditions which development pediatrician himself can deal with. The most important thing I would tell this pediatrician is tell the mother, you do something for 1 month and come back and meet me. Of course, after you've ruled out all the other conditions. And what are the few things? First and foremost, spend time with your child more. Make sure that at least on the weekends, don't keep doing the study, because 5 days a week, 6 days a week, I understand everybody's working. We can't tell the parents leave your job. But tell them at least on a Sunday, then don't hanker after the child only about academics. Spend some time with the child outside the house, going for a walk, going to the market, doing things which the child enjoys. Because the child is actually thirsting to be with the mother and the father. So the most important thing is, don't be a teacher even on a Saturday, Sunday. Don't make the child feel he's in a school or in a jail on a Saturday, Sunday. The second thing for the child is, make sure you make, like Dr. Subramaniam said, make sure you have a detailed schedule for the child. And make sure that the child gets enough playtime, make sure that the child gets enough time to be with friends and is not caught up in school, academics and tuitions all the time. I think that's the second most important part. Third part that I tell parents very commonly is, make sure after 6 or 7 p.m. you don't sit doing academics with your child, at least not at a 5-year-old child's age. Because once you start this homework stuff or what happened at school after 6, 7, 8, 9 p.m., then that is going to always be a cause of a fight and the child is going to get aroused. That's going to cut off the sleep cycle, so on and so forth. So no academics in the second half. Then few other things like sleep. We already spoke about it. So I would expect the pediatrician to talk to the parents that a child at 5 years needs 10 to 12 hours of uninterrupted sleep. So don't let the child sleep in the afternoon, but make sure he can sleep 10, 11 hours at night. So ensuring the child goes to bed early is very important. Other things like diet. Now, there is no evidence to say that increased sugar in foods or colas or something cause a problem. But bigarta kidhar hai? Upendra will be very happy if all of us as pediatricians tell our patients, eat no chocolate, wafers, biscuit, Pepsi, Cokes and colas. Upendra will be very happy. So we must tell them that avoid all these things. And finally, we tell the parents that keep a diary. Keep a diary of all the problems that you are feeling. Oh, today the school teacher said something. Today the aunt said something. Oh, today the neighbors complained. Today people on the playground complained. Is there an actual story of problems arising at multiple? Tumhara taklif kya hai? What is the problem that you are facing? Oh, the child is hyperactive. That's fine. Couple of times complaints on the school ki ek jagah pe nahi baithta. Okay. Taklif kya hai? Has he assaulted somebody? Is he so aggressive to the point that he poked somebody with a pencil and he's done that 2-3 times? Has he pushed somebody and somebody's fallen down and got hurt? So, taklif kya ho gaya? I think it's very important to ask. And finally, as a general pediatrician, you must remember to get the child checked for vision, for hearing, check the child for anemia, like Dr. Subramaniam said, all the other things like Dr. Nandita said. And this is very important. And tell them after 1 month, come back and meet me again. And let's see if your child is doing any better. This monitoring part is very important for the general pediatrician to do, because after 1 month, if she comes and tells you, doctor, it is worse, no problem. Then you refer to a developmental pediatrician. But first, try this yourself. Don't rush to label the child or send for therapy or send for some remedial education or even to a developmental pediatrician or start medications at this stage. Thanks.
Okay, so let's suppose we have a remote control and we fast forwarded and this kid comes, the parents do what you told, and he comes after 2 or 3 months and the symptoms have seemed to be persistent and increasing. And the diagnosis of ADHD, again, fast forward after a year when he's around, or when he's around 7, is now ADHD. And now what would you like the general pediatrician to do to ensure that the parents comply? Because often we get parents who have been started on all the pharmacological and non-pharmacological strategies that you and Dr. Subramaniam outlined, but after say around a week or maybe around 3 weeks, their efforts peter out because they don't seem to see any difference. So how are you going to ask, what are you going to tell the pediatrician to do?
No, you're saying efforts after 3 weeks or after 3 years?
Only after 3 weeks. After 3 weeks, उन्होंने छोड़ दिया क्योंकि बच्चे में कोई फर्क नहीं आ रहा है.
That doesn't mean I need to put him on a medication. I mean, I would defer as a pediatrician or a developmental pediatrician. We have to try and work more with the parents to motivate and convince the parents to do it.
Exactly. So what would you tell the pediatrician?
So I beg your pardon?
What would you tell the pediatrician? How will he convince the parents to do that?
I would tell the pediatrician to tell them that, look, it's very easy for me to start your child on a medication or a methylphenidate. Even the pediatrician can do that. But then the methylphenidate will help as long as it stays inside the child's body, which is 6, 7, 8 hours. और वो जब दवाई का असर उतर जाएगा, the child will go back to being hyperactive. Would you want me to try that way out? Or do you want to still try harder at home? No parents have it very easy in today's life. I know that. I mean, all the parents do tell us. But who are we to assume that the parent can't make that effort? And I quite dislike this thing about where parents should not be stressed. They should not be undergoing. Who said that they are stressed? Let them come and tell me that, doctor, if you tell me one more time to do this, I'm going to commit suicide. Then I'll say, okay, hang on. Let me start your child on medication. Why are we assuming that the parents are very upset? I mean, we are not in the United States by and large. So we should tell them that, no, ma'am, I think, why don't you try? So what we used to do is we put some mothers in connect with each other. And then we tell each of the mothers to give one evening to the children. And we tell the mothers, send your children to one mother's house. So there are various such techniques that can be done. The point is not to jump to a conclusion of a label, because once the child is labeled, like Nandita ma'am said, then everybody wants to keep pushing everything that happens on that child in the class. So I would say resist labeling the child, especially with the history that you give. And again, at 7 years, if he comes, again, I'm not concerned about the diagnosis of ADHD. I'm sorry. I'm going to ask at 7, abhi taklif kya hai? What is happening now? If he's overtly aggressive, I want to find out in the class why is he now pushing and hitting other children? Very often I'll find out that the other children are making a scapegoat out of him. I'll find out that the teachers are already prejudiced against him. Then I have to interfere with the school. I have to intervene and talk to the school. Now, what I talk as a pediatrician to the school is not different from what a developmental pediatrician is going to talk. The idea is all of us to find out where these child symptoms are coming from. The moment we put it in a box called ADHD, then we have pharmacological management and non-pharmacological management. So my message to general pediatricians is avoid that.
Okay. So before we move to the next case, I think what has emerged from all these discussions is that the role of the role, it's not just the role of the developmental pediatrician. There is a major role of the general pediatrician also, because the general pediatrician will be acting as a connect between the family as well as the developmental pediatrician. And the maximal rapport of the family is with the general pediatrician. So if things can be probed into and the parents can be helped and talked about, the level of understanding and connect is a relationship between the general pediatrician and the family has been there since years. So they will listen to the general pediatrician. So we'll just move on to the next case, otherwise we'll run out of time. So Dr. Monica, over to you.
Yeah. So I'll describe another child. This is a 3-year-old boy, and this is another common presentation that we see in our OPDs, where the parents have come with the concern that the child does not sit still. He keeps moving around the house. He's handling stuff in the house. Also, he does not speak very well, and he has a vocabulary of just a few words. Parents are not sure when the speech started properly, but they feel that around 2 years of age was when he started first speaking. He is generally occupied with the mobile phone, and he generally uses the mobile and TV to stay occupied, and that is what the parents use. They use the TV and the screen as a babysitter, including at mean times. There is no significant past history, and the child is not on any medications currently. Next slide. In the birth history, he is a term vaginally delivered baby with a weight of 3 kgs, no problems in the antenatal and the perinatal period. If you look at his developmental history, at present, he is able to climb up and down the stairs. He can feed himself with a spoon. He is able to color within figures. He is able to speak 2 to 3 words with meaning. He can help in dressing and undressing, but he has not achieved bladder and bowel control. He does not indicate his toilet needs. He does not indicate his hunger or thirst. He has been enrolled in a nursery school recently, but he has yet not warmed up to the environment, to the teachers or the peers. He is fidgety in the class, and he does not engage in activities. In the family history, he is the only child of a non-consanguineous couple. The family is a nuclear family, meaning they don't have grandparents at home. Both parents are working. Next slide. On examination, the vitals are stable. His anthropometry, including the head size, is normal. There are no neurocutaneous markers, no dysmorphisms. There are no congenital anomalies. Systemic examination, including the neurological assessment, is normal. Vision and hearing from the history and from the general examination, the OPD is normal. Next slide. So my first question is to Dr. Nandita. What are the cues that you will look for in his behavior and development, or what you would suggest the general pediatrician listening to us today should be asking for to clarify what they are dealing with?
Well, from the history that you have given regarding this child, the parents have come in with a major complaint of poor speech, not talking properly, using few words. That is the major thing that has been harped upon. So I would like to find out what else is going wrong. So generally what I would prefer to start with is give a blanket cover, ask the mother, what does your child do the whole day? That gives a picture. Mother would say, my child runs around or he plays. That's vague. And then we go deeper into it. What does he play with? What are the sort of things? Does he play with toys or household objects? How does he play with them? Does he play meaningfully with them, or does he just bang stuff or throw stuff? What is it? And then in this
shall I respond to your questions?
Yes.
So here I'd like to again point out that the main presenting symptom here is again hyperactivity, where the parents are troubled by the fact that the child is fidgeting with things at home and is really running around a lot. The additional complaint is that he's not talking very well. And your question, to respond to your question of what does he play with, the parents report that he is generally not interested in toys. If they give him many toys, he's generally breaking stuff or moving from one thing to the other. And he is generally running around in the house, and he's mostly occupied with that. And if they want to settle down the child, they usually see that he settled down with a mobile phone or some screen time.
Well, if the parents or the grandparents try to play with this child, is the child interested? If so, for how long? How long can the parents keep the child involved in a play?
Okay.
That is something I would like to look into.
Yeah, it's a nuclear family. They don't have
Yes.
grandparents at home.
Mhm.
Both the parents are working. And what they observe is that the child is generally running around the house. He is difficult to calm down. And because he's not able to indicate his needs, bowel bladder needs, or his food needs, the parents are doing things by time and they're using the TV to keep him occupied, settle down, and feed him, which again is a difficult exercise.
So this part of the history that the parents are giving points towards a relative problem in social skills and play and interactive play, I would rather say. From here on, I would also like to know whether there are any sensory issues in this child. What I would ask is, are there any unusual movements of hands or eyes, or maybe using how does it react to senses, light, sound, maybe smelling everything, maybe mouthing everything, any sort of these issues. If they
So
are
to
present,
respond to that,
yes,
I'll respond to that. He does not really have this habit of smelling or looking at things, but he's generally moving around too much. He's hyperactive. He gets excited very fast. And generally, they observe that when he's excited or even when he's not given due attention, he's flapping his hands in excitement. That is one of the things that they have occasionally noticed. As far as social behavior is concerned, they do take him to the park, but they have observed that he does not mingle with other children. He likes to see the children. He will run into the park and where the children are playing. But generally, the mother feels that he is not really playing with the children. He's just running around in the area where the children are playing.
These are definite social developmental cues which are suggesting that his social skills are not adequate. Maybe child wants to communicate but is unable to do it, which makes him frustrated and fidgety. That may be a cause of the running around, number one. Number two, you've mentioned about flapping of hands and a couple of other sensory issues. So that may also be the vestibular sensation, maybe not absolutely normal, which is making the child run around as a coping mechanism. So what we see is an hyperactivity, maybe due to both of these, the frustration, the emotional part of it, which the child cannot express, and also the so-called neurological part of it, where it's a coping mechanism to sustain this sensory issues. So these are the developmental cues that would look for, which would suggest traits of autism in this child.
So I can see that, Dr. Nandita, you are suggesting that we should be looking at the social behavior, the social interaction, the play activities of the child, as well as some of the sensory things. And while you're thinking of autism, you're also asking for some stims, the stimulating behaviors and hyperactiveness. Okay, I'll draw your attention to the developmental history that I have presented to you, that this is a 3-year-old who's walking up and down the stairs, who's speaking a couple of words. And he's 3-year-old. He's not speaking in sentences, and he's not conscious of his bowel bladder needs. So,
from your history, from your history, domain-wise, there isn't much of a motor delay. Maybe not a very. We haven't really got a history of the fine motor development, which may be slightly affected, but gross motor is more or less running on time. Language is affected, so is social. So maybe we should not consider it as just a delay in all domains of development, rather more of a socio-behavioral problem that we're dealing with.
Right. So we have speech and language delay here, and we have the social delay as well. Whereas motor aspects are more or less normal. And even though the parents are talking of excessive hyperactivity in the child, it looks like he has symptoms more towards autism. So this is something which commonly happens. We see children in the OPD presenting with features of hyperactivity. And as I said before, that hyperactivity is something which gets easily labeled. And a general pediatrician will often miss the fact that this is a social language delay, a behavioral delay, rather than just being pure hyperactivity. I'll open it to the other panelists. If you have any other suggestions, any other questions that you think a general pediatrician must ask to be more clear about what he's dealing with. If not, I think we can move on to the next question then. Sharmila, can we go to the next slide?
Yeah.
So, Dr. Subramaniam, what differentials would you consider apart from what we have just discussed, and how do you want to be clearer about the diagnosis?
Of course, when you're looking at a child who's presenting very early in life, difficulties, developmental difficulties, right from early development.
Dr. Subramaniam, could you be a little louder, please?
Am I clear now?
Maybe
You're
a little
clear,
louder.
but it's very soft.
Yeah.
Okay, 1 minute. Is it okay now?
Yeah.
Yeah. So when you're looking at a child with a developmental problems right from early childhood, you're looking more towards autism. But you also have to consider other sensory issues. I see that in your examination, you mentioned that vision and hearing was normal, but that was based on history and clinical examination. And I would definitely want to document that much clear, because we find that a lot of children who have hearing deficits, like because of repeated AOMs or serous otitis media, who present very similar with similar features like hyperactivity and inattention, and features that are suggestive of autism-like features. So it is very important for us to get this hearing checked, get a proper hearing test done, and document that well. So that is one issue that I would definitely like to consider. Preschool ADHD is definitely a concept that is catching up with in a lot of Western countries. That can be one of the differential diagnoses. So autism, ADHD, there is preschool ADHD, and other major sensory deficits like hearing may be definitely a consideration here as a differential diagnosis. And how would you establish a diagnosis? As I said, I will definitely get a hearing testing done. I will get his eyes checked properly by an ophthalmologist and get those values done. I would also go for a proper clinical scale by at least 2 scales, one scale based on history and one scale based on the examination of the child. So there are various scales for diagnosing autism. So you base it on this. Basically, the child should fall into, these scales are falling into this DSM criteria of at least having persistent deficits in social communication and have RRBs, repetitive and restrictive behaviors and interest. And these two, along with symptoms occurring very early in life. Now, this should cause significant impairment in the child's function. These are the important criteria, and most of the scales follow this criteria to give us a diagnosis.
Right. Thank you, Dr. Subramaniam. While we are looking at the DSM-5 criteria, for a general pediatrician, I would say that even when you're taking the history and when you're looking for the cues in the behavior, try to ask questions which focus on these areas. You can ask more questions about the language, about the social interaction, how the child looks at the child, how the parents play. Like we have discussed earlier, Dr. Monica also said that you should discuss more about how the child plays with the parents, plays with the peers, plays with people in the classroom, and how the interactions are. Try to ask more questions about that. Secondly, ask questions about repetitive behaviors. Some of the common repetitive behaviors are what we call as echolalia, just repeating your question or repeating whatever the child has heard, humming to oneself, shaking a leg constantly, or having excessive movements. Even hyperactivity itself can actually be a self-stimulating behavior. So for a general pediatrician, when you're taking the history, we don't want you to be sitting with a DSM-5 criteria, but try to see that you include these questions. And as the bottom line says, if there are no other reasons to explain the behavior, then probably we are going towards the behavioral disorder. Let's go on to the next slide, Chandra. Dr. Subramaniam, do you have something to say?
Yes, symbolic play is one history that we can definitely ask for.
Yes.
How the symbolic play is developing. There is a pre-symbolic phase, there's a symbolic phase and advanced symbolic phase, and that would also be useful. Because of short of time, we wouldn't go into details, but I think we can look up on that.
That's a very good suggestion. Most of us at home for children, we have those tea sets, we have dolls. In North, we have something we call as ghar ghar. So you can ask the parent if they are getting involved in those kinds of plays. Okay, so the next question is for Dr. Sameer. How would you manage the child, and what non-pharmacological modalities would you suggest to the parents?
Yes, so I'm just going to go back a little bit to what was discussed previously in the symptoms of the child. And I think sometimes it might be difficult for the pediatricians also to go through all the DSM in questionnaire in detail. One quick simple thing that I'm going to say that I use in my practice, and that's a disclaimer, it may not be in the books. I find that these children have a basic problem that they are object involved and too little human involved. So I call it in Marathi or Hindi, Ati Vastu Magnata. The child is too involved in objects and manushya magna kamtarta. that they are not involved in humans. Given a choice, the child will always gravitate towards an object rather than humans. I think this is one very important thing that we must tell them, or we as pediatricians must look out in the OPD. The second is, if a child can't answer in simple conversational English or conversational language for his age, but has a non-stop repertoire of phrases that he has by-hearted, and this is very difficult to explain to the parent that this is not normal speech, this is echolalia. So I think these are two of the issues. Coming to the current slide, if there are comorbidities, I would request the general pediatrician to understand that there are some basic drugs that can be used in the management of hyperactivity. I'm sure you all know about methylphenidate and you know about atomoxetin. Now is not the time to talk about it in detail, but a simple tip to the general pediatrician is, don't worry too much. Just make sure that you give the smallest possible dose that is dispensable. If it is a tablet of 10 milligram, give half a tablet. If you can break it into 1/4, give 1/4. If it is a tablet of 5 milligram, like one brand of methylphenidate available at 5 milligram, give half of that. Start with the lowest dose and see what happens. Don't be afraid of that. So either methylphenidate or atomoxetin for hyperactivity. Risperidone is available as a liquid, so you can start with 1 drop. In our clinic, we use a tuberculin syringe without the needle, of course, to explain to the parent how to do it. So start with 0.1 ml or 1 drop of risperidone if you have a lot of aggression or hyperactivity in the child. Also, it helps a lot of sleep control or getting the sleep regulated. The third drug that many people do use is an aripiprazole. I don't have much experience with it, but the fourth.
Can I interrupt you, Dr. Dalwai?
Yeah.
I was looking for some non-pharmacological suggestions from you.
Because the first line came as managed, so I thought I'll just say that. But I'll go on to the next part. The last drug I was going to mention is fluoxetine. Now, going on to the non-pharmacological modalities, what I'm going to say is pretty controversial because the world believes that nothing can be done. Hence, keep doing OT, PT, speech therapy, and ABA. These two go hand in hand, by the way. It doesn't say that if you want a child to become normal, do OT, speech therapy, ABA. That's my first point. Thus, yet, for 20 years or 15 years, IAP, through our platforms, including me, all of us have been giving a message to our pediatricians. Child with autism, refer for OT, speech therapy, or ABA. I think this must stop because there is no correlation between autism getting better and doing OT, speech therapy, sensory, remedial, etc., etc. All of them are important, but not as an exclusive prescription ki zindagi bhar ye lete raho. That's not appropriate. If you look at ABA, for the last 1 decade, we kept hearing evidence-based means ABA, best evidence-based. Last 3 months back, somebody sent me a snippet from the US that the American Medical Association is now says ABA is rubbish. And now they have some floor time or relationship or this or that. Now for 1 decade, we'll keep hearing evidence for those methods. Again, after 1 decade, we will see that evidence has gone out. So I have to say that eventually all development pediatricians and pediatricians need to work together to find out what is working for your child in India. And it is an eclectic mix of all of this. So the duty of the pediatrician and the developmental pediatrician is to find what is working for this particular child. And hence the most important point is not starting the therapy, but the more important point is monitoring the results of that therapy. And one last statement I would like to say, please, for God's sake, if you have a choice, then don't say anything at all. But don't say do OT and speech therapy or wo karte raho, because you have no clue how many parents keep doing that for 10 years, 15 years and are not very satisfied. So don't give these blanket suggestions. Finally, few things that you can tell the parents to do. Please stop the screens. Please stop all screen time. Please stop the child from having too much objects. This play therapy for autism, I mean, again, this is controversial, I know, because many people have a different thing. A child with autism will be involved with play all day, but by himself. Is that normal play? No. But pediatricians might end up picking this and saying that, okay, let your child play. No, the child is going to get more repetitive. Lining up of objects, it's meaningless play. So we have to be very careful when we use these terms. So I would say make the parents spend more time interacting with the child face to face, sitting down on the ground, attracting the child's attention, hugging the child, kissing the child. Make sure you are drawing your child's interest towards you. By you, I don't mean the biological mother. I mean any human being who has the time to do it. It doesn't have to be the biological mother all the time. And as far as possible, stop teaching your child nursery rhymes 1, 2, 3, 4, ABCD, Shakespeare, etc. Because this is only inducing echolalia and worsening human interaction. I think these are the few things that I'd like to say, but I'm sure all of you can add on to that.
I think we can go to the next slide.
Okay, I'm so sorry. I didn't realize that there was a question on this. My apologies. Dr. Juneja, ma'am, I'm so sorry. My apologies.
Oh, okay, to apologize,
So,
Dr.
the
Dalwai.
question for Dr. Monica.
There's something wrong with the
Right.
audio.
It's all right. We'll modify this question. We've heard about the. Am I audible?
My sincere
Yeah,
apologies.
I think I'm having a connection issue. Am I audible now? No, it's absolutely all right. The question actually I was going to put to ma'am was that we have heard of all these drugs now. Now, when we have a child who has hyperactivity with autism, which would be your drugs of choice and what are the commonly used drugs?
Can I just add another question to that?
Yeah.
Dr. Monica, I would also like you to answer this question. Is there going to be any difference in the medication in a child with ADHD and hyperactivity and versus the medication that you will use in a child with ASD and hyperactivity? Given that the child does have indications for drugs in both these cases.
Okay, Dr. Sharmila and Dr. Monica, thanks for this very important query from your end. I hope I'm audible because there seem to be some issues with the signal. So Dr. Dalwai has already clarified that you need medications in many situations in these children. So if there is a child who has plain ADHD with hyperactivity and a child who has autism with ADHD, so in both these scenarios, the medication that we use is so the first line that is recommended and for which the evidence is available is methylphenidate itself. But we have to be careful that in ASD, when you're giving the medication, you have to be very careful about the not only the effect of the medication, because it is likely to be, so when we start methylphenidate, we start slow. We titrate it very carefully because the side effects are more common. Then the effect may not also be as good as in plain ADHD. So we start slow and titrate gradually. But in India, there is a difficulty in procuring methylphenidate for children with for any child. So in case there are other comorbid conditions like hyperactivity is associated with aggression, sleep problems, feeding problems, which are common comorbidities in children with autism, then we commonly would start with risperidone because that is going to target the other comorbid conditions as well. And the parents would be much happier than giving just methylphenidate because it may cause sleep issues. It may worsen the sleep issues. The appetite comes down further with methylphenidate. The child may become more irritable and it is difficult to get it. So even though the evidence is more for methylphenidate, many a times, keeping all these things in mind, we usually start with risperidone, and that too in a low dose at night because we first want to take care of the sedative side effect. And we don't want child to be so drowsy that the child does not perform during his various activities during the day. Apart from this, if we are giving methylphenidate, we have also seen that because the methylphenidate is a short-acting medication, its levels in the blood wax and wane. So a child with ASD may get very irritable because the levels of the chemicals in his blood are varying, and that becomes much more uncomfortable for a child with ASD, and he or she may not be able to verbalize that he is having this symptomatology. So we've seen that sometimes when we start methylphenidate and the doses are not maintained properly, are not titrated during the day, the child may in fact become more irritable and the problems may worsen. So these are the two main things that we focus on when we are taking care of ADHD in children with ASD. Apart from this, behavioral intervention, which is specific for ASD, has to be continued and has to be the main focus of intervention in child who has ADHD along with ASD. Even though atomoxetine was another medication which is prescribed for children with ADHD, but it takes longer time for its effect. And if the child is having marked hyperactivity with ASD, sometimes the control of hyperactivity is very essential to even start the intervention. So in such situations also, methylphenidate or risperidone might be a better option to start the intervention with. Internationally, long-acting clonidine is another medication which has been found very effective in children with ASD and having ADHD. But unfortunately, that long-acting preparation is not available in India. And though we can still use the short-acting routine clonidine in these children as well, but we need to monitor for the side effects very diligently. So I hope I have answered the query.
Ma'am, may I ask you a question? Ma'am,
Yeah.
suppose we have a child with ASD and hyperactivity, and apart from hyperactivity, the child has other behavioral issues which warrant the use of risperidone. In that case, do we start risperidone plus methylphenidate, or do we wait for the effect of risperidone to come and then, if required, add methylphenidate?
Mostly, I think it is for most of the medications, it is best to start with just one medication and titrate it, because polypharmacy is difficult to monitor. The side effects become confusing. The effect becomes confusing. So we usually start with one medication. So in this case, we will first start with risperidone, gradually titrate the dose. And mostly we are able to manage children with risperidone only. It is very uncommon that the child may have to be shifted to methylphenidate in this situation. And that is also commonly because the child becomes too drowsy during the day. And so the intervention is not very effective. So if the sedation becomes a major problem, then only we shift to methylphenidate. Risperidone also is very effective in self-injurious behaviors. So children with ADHD and ASD are generally having more severe autism. They are more likely to have all these comorbid conditions, including self-injurious behaviors. We've seen children coming with scratches and bleeding all over, and they would also respond to risperidone pretty well. So I would start risperidone alone in these children as the initial medication. But we should watch for the side effects of risperidone also, the tardive dyskinesia and other problems. And if it is taken for long, then prolactin levels also may, and dyslipidemia become a problem in these children as well. So we need to monitor for that.
Can I take one comment from you on aripiprazole? I think our general pediatrician friends would be noticing a lot of aripiprazole also being used in children with the autism and ADHD.
We have used both aripiprazole and risperidone in our children with ASD. Mostly we start with the risperidone. If the child is not able to tolerate risperidone, we have shifted to aripiprazole, primarily because the side effect of tardive dyskinesias are reported to be less often with aripiprazole. But it is not a golden rule. We have seen children having problems with even aripiprazole. So whenever you start any of these medications, we have to be monitoring these children very carefully and closely, because even though the side effect may be lesser with aripiprazole, the efficacy may not be very good as risperidone in some situations, and the side effects are equally likely, or maybe somewhat less likely, but very likely. So monitoring again is very important.
So I suppose we should leave it to the developmental pediatricians to be adding on to the pharmacological modalities and also for monitoring of that. So I think we have come close to the end of the second case, Dr. Sharmila.
Yeah. So I think it's been a very, very, very fruitful discussion. And to summarize the key points that have emerged, like any other clinical scenario, clinical diagnosis, for a child with a behavioral problem and hyperactivity, you need to use a stepwise evaluation. You have to do an in-depth history across settings and persons. Is the hyperactivity only in front of the mother who's indulgent? not in front of the father who is stricter. The examination and the observation of social interaction, behavior, and play, all these are integral components. You need to exclude other medical, sensory, psychosocial, and environmental factors that may be attributing to the hyperactivity. And all these have beautifully been, although I'm saying it as although we are the moderators, but it has come out very well during this discussion, how to ask the suitable questions to the parents. And if the parent suggests a neurodevelopmental order, apply the relevant diagnostic criteria based on the clinical information that you have obtained from your history and examination and observation. And I'll digress here for a moment. All of us during the COVID era, when the diagnostic criteria came out for MISI, I mean, when I saw the MISI criteria for the first time, I was like, my God, what is this? But by the end of 2 years, we were also familiar in applying the criteria. It became second nature. Similarly, if you are familiar with, if you familiarize yourself with these criteria, you just need to fit in the blocks, take the history up to see whether they apply or not. And if you suspect a child with a neurodevelopment disorder, then you must refer to a developmental pediatrician. And as I said earlier, you must stay in connect with both, because you are acting as a bridge between both. And whatever it is, usually the family trusts the pediatrician much more than the developmental pediatrician. And I would also suggest that since there are lots of kids who do come with special needs, each one of you needs to develop a network in which you have a person a developmental pediatrician who you can trust, who you can talk with, who you can discuss cases with, so that you are all on the same platform and you can, including the parents, and there is no inconsistency in the information that is being given to anybody. And that is why the compliance with the instructions of the family also usually is better. Ensure periodic follow-up, find out whether the parents are complying with the management. And as Dr. Monica very correctly said, it's better to leave the medication to the developmental pediatrician. But yes, look for the side effects as you whenever the child visits you. And another thing that you must remember, that as the general pediatrician, we have responsibility for these kids till at least 18 and late adolescence. So you need to provide continuity of care throughout. It's not that you just suspect, refer, and forget about the kid. You have to continue giving care for all other non-special need conditions to that child. So the last thing I'd like to say is that all that glitters is not gold. And similarly, hyperactivity is not equal to ADHD. Hyperactivity is just a symptom, and just the name ADHD, because it has the word hyperactivity, does not make it ADHD. You have to explore all the other conditions that have been elaborated upon so beautifully by everybody. So I think from my side and Dr. Monica's side, we end here. If the panelists want to add anything, and the organizers, please feel free to continue.
Thank you, Dr. Monica and Dr. Sharmila, for moderating it so well.
Thank you.
Can you please stop sharing? Can you please stop sharing, Dr. Sharmila and Dr. Monica?
Sure.
Actually, we are left with not much of a time for question answer, and I think you have given such an elaborate kind of a presentation on hyperactivity that there are hardly any doubts left. Obviously, we as a general pediatrician also understand our limitation in treating this kind of children. The first, perhaps the block for a general pediatrician is the time that he can allot to an individual patient. And I believe this problem to tackle, you really need to give a lot of time. So if you're looking at the pediatrician working in a metropolis who may be having an appointment of 15 or 20 minutes each patient, going to the periphery, the appointment shrinks to 5 to 10 minutes. Dr. Vaidya is staring at me and he very well understands what I mean to say. So in a peak epidemic period, a given pediatrician may be seeing about 100 patients in a OPD where it's very difficult, or maybe the priorities do change. So with that, just a couple of questions. Is attention or this hyperactivity a genetic problem or an epigenetic problem? how far a genetic cause has been defined so far? A lot of things are defined by genetics. So is this a genetic problem or epigenetic problem?
Sharmila, do you want to answer?
Where is Dr. Monica Judeja?
I think she left. She just messaged that she has another meeting, so she has left.
Okay. So I would rather say Dr. Monica, aap le lo.
Okay. I would say that there are multiple causes for hyperactivity attention disorders, and it is known to be associated with a lot of syndromes. For example, Fragile X syndrome is one of the very commonly known syndromes associated with hyperactivity and other behavioral disorders. So there may be situations where you can associate to genetics. It may be inherited. There are autosomal dominant and recessive conditions which are known to be associated with behavioral problems. But you cannot say that all hyperactivity disorders are genetic. Some of them may be secondary to other conditions as well.
Quite often a child is brought to our OPD, and by the experienced pediatrician, many times they quickly remember, sort of recognize this is 4-year-old child, his behavior looks abnormal. So he recommends to go for evaluation to a development expert. And the first mode is denial. My child is normal. Biggest problem is even the educated parents, my child is normal. How do you overcome this denial? Because unless and until they accept there is some problem, at least to be evaluated, your treatment is, far-fetched thing, kind of a dream to be achieved. But first is acceptance by the parents. So how do you address to this denial mode itself?
I have a point to add here. Though it starts with denial, from our point of view, if we are a little complacent with them and take them through their journey, how does your child behave throughout the day? How does the day go? They will themselves come out with the problems one by one. And then we can say, okay, if these are the problems you're facing, they won't say that at the beginning. At the beginning, it's say, this my child doesn't talk. That's it. At the end of this storytelling, the things will come out from their mouth. Then we can utilize it.
I think I would rephrase that as the parents' denial should not be met with the doctor's denial of the parents' concern. So if the parent says, no, my child is normal, I think we should not be pouncing on the parent to say that, no, you're not listening to me, you don't understand what I'm saying. Rather, we need to acknowledge the parents' concern and bring it out from them, like Dr. Nandita said, help them realize that they are dealing with a concern, which is why they come to the doctor's clinic. Otherwise, they wouldn't.
But then how do you respond to the answer from the mother? No, his dad also behaves the same way.
Yeah. May I answer that?
Yeah.
Yes.
Because let me just disclaimer. I am a general pediatrician first, then I'm a developmental pediatrician, and our OPDs are also equally busy. So what I do is that see, and lots of kids I have diagnosed lots of kids with ASD who didn't even come with behavioral problems. A very common comorbidity is abdominal pain, recurrent abdominal pain. And these kids have come with recurrent abdominal pain, and the parent has been visiting doctor and has so many ultrasounds and investigations and have not found a solution. And when the child has been brought, then when we observe the child during the history, then we kind of figure out that this child has autism. So the parent has come with a totally different issue. And here you tell them that this child has a developmental or behavioral problem. It just doesn't sit well with them. They just refuse to accept it. So for those kind of parents and other parents who are in denial, the first thing is that, as Dr. Monica said, don't pounce on them. You have to get them within you. You have to walk with them. Only then will they understand. And one of the things is that it may not be denial. Sometimes it's just plain and simple ignorance. Nowadays, parents, because they're nuclear families, they just don't know anything about, their knowledge about child development and other kids and their social interaction with other people and other families and other kids is so minimal that they have no idea how a normal child should behave, should play, should interact. So for them, their child is normal. So what I do is that I ask them to make videos. I ask them to answer questions. And as I said, what happens is that since you're making them a partner in this whole endeavor, then you can also, you're also saving on that mujhe abhi batao wala jo problem aati hai na, that you can kind of stagger it over 1 or 2 visits twice a week. They make their videos. When they make their videos, when they see other children playing, when they see and they can compare, then gradually the truth emerges. And it's very, then when you sit with them and you show them the video and you say, देखो आपका बच्चा ये कर रहा है, वो दूसरा लड़की जो दूसरी लड़की है वो ये कर रही है. So it finally makes them realize, but it can never be done in one sitting. It's a gradual process that does take around 3 or 4 things. And then once they do realize it, that same child, the same family will become an active partner and will help.
Dr. Subramaniam wanted to say something.
Yes, sir. I use what is called the spike protocol, which we use for breaking bad news. We also use it here. Spike protocol is yes is for setting. You make sure that parent is in a proper setting for them to listen to, make them sit down. Don't just explain to them on the go. Second is to first listen to their perception, find out what is their perception of the problem. So that way you are able to understand the cultural and social background with which they are coming to you. The next is then you ask the parent whether you want more information. For example, they have come for fever and you find or abdominal pain, and then you find there is a behavioral problem. You can ask the problem, I find certain behavioral issues. Do you really think you want to discuss it now? No, most of them will say yes, but then nevertheless make them say that so that you are invited to give that information. That is I. K is knowledge, which is the you give them knowledge of why and how this is happening, that we are very good at. Now that they've invited you, they'll listen to you. Then next step is to empathize with them. You have to tell them, yeah, I understand you had come for only abdominal pain, but then see, this is what is there. That's why we are telling you. I know it's a shock. I know you have not come with your husband. I know you want to discuss with me again regarding this. So empathize with them. And the last one is SS strategy, which is try to enumerate what is the next step. Don't just leave them with the problem. Try to tell them there are solutions, and those solutions have to be clearly enumerated. Now, this can be done within 5 minutes, even in a busy OP. And this way, you have an organized thought process on how you are going to go about telling a parent any bad news, specifically a bad news as bad as trying to say that your child may have ASD or hyperactivity. Sorry.
Yeah, Dr. Vaidya, please.
Yeah, excellent, Mahesh, what your point brought out. But I am a totally general pediatrician. But what I learned and followed, many patients, when we ask them this is looking abnormal, first is a denial mode. But many times I counsel them, this is a denial. I do understand your child is normal. But with my experience, I daily see the children, and I think there is some different behavioral problem is there. So for me, you get the developmental pediatrician's opinion. So then they are little bit for 2-3 patients, I ask them to don't give my fees. You just go there. And then literally what they found, you come back and they say, thanks, sir, you got the point, and we had, and they brought the other children. When they observe the other children are behaving little like their children, so they brought their children, family also. He will go to sir and they take opinion. This is my personal opinion. Is that I like that also. For my sake, you get to it. If it is okay, then it's 100%. We are very sure. But if there is some problem, then you can have solution. So at least for me, you get this. And 2-3 patients, they literally got better also there.
One more question. How does dyslexia add to the problem or contribute to the problem, or can be a primary reason for the problem of hyperactivity? Have you noticed that? You work out the child completely, you find some subtle dyslexia that is being presented to you as hyperactivity. Have you come across this kind of a scenario?
Every day, sir. And madam had even pointed out during her presentation that whether it's a chicken or the egg, we don't know, because learning disabilities, dyslexia is a type of learning disability, and there are other varieties also. So are in common association with hyperactivity, and we don't know whether it is the dyslexia or the learning disability which is causing the child not to have ability to concentrate, or it is the other way around. They are often comorbidities and should be one. If one is found, the other one should also be looked at. So it's a very common comorbidity, and almost every one of us understand, and we have to look for it.
Dr. Nilima, you wanted to
Start
ask
using the word learning problems rather than saying learning disabilities, because the incidence of learning problems is much higher rather than saying dyslexia, which is actually a specific learning disability. It could be an independent condition, independent of the behavioral problems.
Usually we get, as sir said, denial is the first step from parents, what we get. At the end, when the patient goes to the developmental pediatrician, starts with some therapies, still he has belief in the general pediatrician whom has referred him. So they come back to us and they ask the question repeatedly, ye theek ho jayega kya? is it curable? So how to handle this question? And this is true for autism, hyperactivity, dyslexia, all three conditions.
I think honesty is the best policy, and we should give them the real picture of what the condition is. And once you feel that your parents have understood, you need to explain to them that this is a lifelong condition. We are not going to cure the child, but we are going to bring the child as close to being functional in his daily activities and being within the society. We need to be truthful.
What I say is that आपका बच्चा like cure हो या ना हो, बेहतर जरूर होगा. So once you tell them it's like baby steps, dhire dhire, you say that, okay, like when a child enters school, when he enters class 1, you can't start dreaming about what he's going to do in class 12. You have to go through each of the steps. So similarly, it's like this, gradually, dhire dhire behtar hoga. Kitna behtar hoga, kitna time lagega, wo that only time will say. But the thing is, agar aap nahi karoge, so instead of going stepwards up, you're going to go stepwards down. So the thing is that if you tell them the faidas as well as the consequences of not doing it, then they usually take an educated decision.
Subramaniam wanted to say something.
Sir, I feel that these are not diseases that we are trying to cure. So that's the first thing that I would like to tell them. We are not looking at disease, we are looking at neurodiversity. So I try to tell parents that we are not looking at diseases that you cure a child of. These are basically neurodiversity. I give them my example. My handwriting is very poor. Nobody can cure me of my disease or my lack of good handwriting. I can't write spellings properly, but that doesn't mean I can't circumvent it and be a good doctor. So there are ways to circumvent it and live life to the fullest extent. But trying to look for a cure for a non-disease is not going to be possible. So I take them away from the concept of a disease and a cure. And from there, I look at it as a condition and how you are going to work with it. That is how I take the discussion forward, so that I take them out. Just because we are giving medicines, it does not mean it's a disease that we are trying to cure.
Mahesh, can I ask?
Yeah, please, last.
About this pharmacotherapy, we do a developmental pediatrician have started medicines. We do observe the side effects and everything. For how long we have to continue the medicines, the first part, and what is the role of melanin in sleep disorders, in particular these children? Is there any role or what exactly?
Melatonin.
Yeah.
I think if I were to answer, I would say that medications are required to tide over certain problems. For example, in hyperactivity, if it is a severe hyperactive disorder, you need to tide over the basic learning phase in school. And for severe disorders, you may have to give it for years together. 2 years is what I would suggest for moderate to severe hyperactivity disorders. It could get longer if the child is in early school and is not able to cope up with the studies. And once you feel that a child has come down to a very good functional level, you could probably start by giving drug holidays and then judging if the child can be taken off. So there's no set prescribed period or duration for which you want to give the medication, but it can be long term.
But for melatonin, I would add that before you start considering melatonin, it's very important to see whether the sleep hygiene is first appropriate or not. If the parents are going to sleep late, if the screen time, the usual scenario that is prevalent nowadays, those things have to be rectified. And after that, once you're sure that the sleep hygiene is okay, then you can consider melatonin if there is considerable functional impairment in the sleep.
Right. And in places where you cannot take care of the sleep hygiene because of the parents' working condition, I think mild, harmless sedatives like pedicloral, Finargan, they have been proven of benefit as well.
Okay, I think we have done an extensive kind of a discussion on this topic almost for 2 hours. I'm just checking my watch. 1 hour, I think it's nearly 1 hour 45 minutes. In spite of it was delayed by 10 minutes, but you almost finished 1 hour 45 minutes. That's something amazing, and the time really passed so nicely. And I'm sure there are a lot of value additions.
I kept on waiting कि अभी दंडा पड़ेगा.
नहीं पड़ेगा, वैसा कभी नहीं होता है. We got some kind of a buffer time always left for it. So thank you very much for being here, faculties. First of all, thank you very much our IAP President Upendra Kinzavdekar for having these sessions of Academic Pearls, and we really have wonderful Academic Pearls so far. We almost finished 9 months. This is September, which was for growth development. And thank you all faculty for sparing your valuable time for giving these insights. And I'm sure we'll invite you again and again for similar kind of topics in future. Thank you very much all. It's over to Dr. Nilima for announcing. We are next month onward, we are starting the hematological month. Next is all hemat topics. So it's over to Dr. Nilima for announcing the session on next Tuesday. Dr.
Thank you,
Nilima.
Mahesh.
Thank you.
everybody.
All
Thank you.
panelists for giving us the last growth and development session, wonderful panel discussion. Next week also we are having panel discussion on bleeding child, and the contributors are Dr. Deepa Trivedi, Dr. Sandhya Gupta, Dr. Anand, and Dr. Shirisha Rani. So next week we are switching gear to hematology. Thank you all.
Thank you all.
Bye.
Thank you very much.
Thank you.
Thank
Bye.
you, everybody. Thank
Yeah.
you.
Thank you all.
Bye.
Thank you all.